I have been an anesthesiologist for over 30 years, and today I want to talk about a medication that may be one of the greatest paradoxes of modern medicine, dipyrone. Dipyrone is also known as metamizole. It was developed in Germany in 1920 by Hoechst and began to be marketed in 1922 under the name Novalgin. Here in Brazil, it's known as Novalgina, and it's found in the formula of very popular medications like Dorflex, Neosaldina, Benegrip, Lisador, and it's also sold as a generic medication as monohydrated dipyrone. It became one of the most widely used analgesics and antipyretics in several countries around the world, including Brazil. Anyone who works in the emergency room, surgical center, or intensive care unit knows this medication very well because it is inexpensive, effective, can be administered orally, intravenously, or intramuscularly, and occupies a very important place between simple analgesics and opioids. Opioids are those very potent painkillers used for more intense pain. They act directly on the nervous system, reducing the sensation of pain. When used correctly, they are very useful, but they also carry serious risks, such as dependence, tolerance, overdose, and respiratory depression. Examples of opioids include morphine, oxycodone, codeine, and fentanyl. But there is a controversy that has lasted for decades. In the United States, the United Kingdom, and some other countries, dipyrone was withdrawn from the market because of the risk of a granulocytosis, which is a rare but potentially serious complication involving a significant drop in the body's white blood cells. Meanwhile, some countries with very strict regulatory systems, such as Germany, Spain, Portugal, and most of Latin America, have continued to use dipyrone for decades. In over 30 years of anesthesia, with tens of thousands of patients treated directly or indirectly with dipyrone, I have never witnessed a single case of a granulocytosis attributed to it. I've also never heard of a case reported by any colleague I've worked with. Of course, personal experience does not replace science, but it is part of the discussion. And in recent literature reviews, I noticed that this is exactly what comes up. A granulocytosis caused by dipyrone does exist, but it may be much rarer than previously thought. The numbers vary quite a bit between studies, ranging from very low estimates on the order of a few cases per million to higher estimates, sometimes in specific populations. In other words, the risk exists, but the true extent of this risk remains unknown. Now compare this with paracetamol, which is perhaps the main substitute for dipyrone. In clinical practice, most doctors consider dipyrone to be more effective than paracetamol for controlling high fever and moderate pain. In my personal experience, this is a fact, and paracetamol is far from being a harmless medication. In fact, paracetamol poisoning is one of the main causes of acute liver failure in several countries around the world. A single overdose of paracetamol, even if accidental, can cause severe toxic hepatitis, liver failure, the need for a transplant, and even death. In addition, there are also serious skin reactions and other important adverse effects associated with the use of this medication. And here's something curious. In the United States, dipyrone is rarely studied because it isn't used, and it isn't used because it's rarely studied. And here is the main issue. When a country bans dipyrone, it takes away from doctors a cheap, effective, and non-addictive option for treating moderate pain, creating a gap between paracetamol, anti-inflammatories, and opioids. And I'm not saying that the absence of dipyrone, for example, caused the opioid epidemic in the United States. That would be an oversimplification, of course. But the opioid crisis involves excessive prescribing, aggressive marketing, social, economic, and regulatory factors, and perhaps the absence of other medications that could have been used. The question is legitimate. If there had been an effective, cheap, non-opioid analgesic widely available for moderate pain, would some of these patients have needed to move on to opioid use so quickly? We may never have that answer, but it's impossible to ignore the contradiction. Some countries ban dipyrone out of fear of a rare complication, while at the same time dealing with an opioid and fentanyl epidemic that kills tens of thousands of people every year. More than 100 years after its creation, dipyrone continues to divide opinions. For some, it's a dangerous drug. For others, it's one of the most useful painkillers ever developed by medicine. And maybe the biggest lesson from this story is this. In medicine, different countries can look at the same scientific data and reach completely different conclusions. Dipyrone is banned in some of the richest countries in the world and is used daily by hundreds of millions of people in others. Who's right? Maybe that's exactly the question that the current scientific method still can't answer.